Good morning, everyone. Welcome to this session of the Arrhythmia teaching program for the DNB students from the Indian Heart Rhythm Society, which is always done on the Sundays, first Sunday of every month. And this is about 2 hour session in which eminent faculty for cardiac electrophysiology and patients from across India and even sometimes abroad participate in explaining the core concepts of electrophysiology topics to the DNB students. And today we have a very special session lined up for you. And this is going to be on accessory pathways. And it is being presented by the renowned faculty from the Christian Medical College, Vellore. And to start the session, I would request Dr. Sirish Chand Srinath, who is a faculty at the Cardiac Electrophysiology Services in Cardiology Department at CMC Vellore, and he would be speaking on applied anatomy relevant to the accessory pathways. Dr. Sirish, please.
Thank you, Dr. Vivek. Good morning, everyone. My name is Dr. Sirish Chandra. I'm Associate Professor in CMC Vellore. By the way of introduction, today we'll start with anatomy of accessory pathways. So all of us would have seen this kind of schematic picture, simplistic schematic picture where you are shown a mitral annulus, tricuspid annulus, and you have free wall, the left free wall, the right free wall, and the septal, and with the distribution of the accessory pathways. What I'll try to do today is to get into more details, slightly to have a more solid anatomical foundation to understand the electrophysiological principles of accessory pathways. For those who are going to pursue a career in electrophysiology, this is absolutely important. For those who are not going to do that, probably it's not very critical, but still it's good to know. So I'll start introducing the anatomy of the AV grooves and AV annuli, and also how the pathways are located, briefly about free wall accessory pathways, and then in detail about septal accessory pathways. So I'll try to strike a balance between giving too many details, also at the same time making it very simplistic. So we'll start with this schematic on the left and an anatomical specimen on the right. This anatomical specimen is in LAO view. The ventricular myocardium has all been removed so that you can see the annuli. This roughly corresponds to this schematic where you have the mitral annulus to the right of the screen and the tricuspid annulus onto the left of the screen. You also have this septum in the middle. And what you can see here is the aortic root or aortic valve where you have the sitting right in between the mitral and the tricuspid annuli. The lowermost or the posteriormost sinus in this picture is the non-coronary cusp. One anteriorly is the right coronary cusp and one to the left is the left coronary cusp. So all the specimens in this specimen photographs in this presentation are taken from these two excellent resources. One is McAlpine's Atlas and the other recent modification and update done by Dr. Moria and Shivakumar. Both of these are excellent resources. The dissections in these atlases have been done from the perspective of interventional cardiologist or electrophysiologist. So these are very good resources which every interventional cardiologist and electrophysiologist has to go through or have as a standby. So we have seen that there is a septum, the non-coronary cusp, the right coronary cusp, and then we have the left coronary cusp. We have what is shown in red is penetrating bundle of his right at the junction of the septum and the non-coronary cusp. So we'll continue with this specimen. So most free wall pathways, so most accessory pathways, almost 2/3 of them are present in the left free wall or the left AV groove. They usually occur between the 12 o'clock position and around 6 to 7 o'clock position on the mitral annulus. It's important to know that there are no pathways in this region between 12 o'clock mitral annulus and around 9 o'clock mitral annulus. The reason being, you can see that the aortic valve is adjacent to the mitral annulus, and also you have the aortic annulus continuous with the mitral annulus, forming the so-called aortomitral continuity. All around, the ventricular myocardium and the atrial myocardium are close, just separated by the annulus fibrosus. But in this location, there is no ventricular myocardium because of the aortomitral continuity. And so there are no accessory pathways seen in this region. Only a handful of very rare accessory pathways have been described in this region. The second then there is a right free wall accessory pathways which occur between around 2 o'clock on this picture and coming to about 5 o'clock on the tricuspid annulus. These form about 10 to 12% of accessory pathways. The second most common site of accessory pathways is actually the posterior aspect of the septum, so-called posteroseptal region, which to a purist is actually a misnomer, but we commonly use this term posteroseptal. This posteroseptal region is a complex region, which I will try to discuss in greater detail slightly later. And then here, about the anterior and the mid-septal pathways comprise about 8% of the accessory pathways. So we'll just briefly discuss about the free wall accessory pathways. In terms of anatomy, there is not much in terms of to discuss about free wall accessory pathways. A few details are like, if you see this picture of a longitudinal section of the left AV groove, the left AV groove is shallower. The mitral annulus is much more robust structure compared to the tricuspid annulus. And histologically, studies have shown that the accessory pathways are just skirt the annulus. They're very close to the annulus in this on the left side usually. And also usually the left side pathways are thinner. Of interest is the fact that the accessory pathways are actually made up of working myocardial cells. So the connection expression is very similar to the working myocardial cells. They are not conduction system. So the point is that they skirt the annulus on the left side very close to the annulus. So generally, when we are ablating these pathways, we can go transeptally, approach it to the left atrium, and ablate it close to the annulus at the atrial insertion site. We can also go retrogradely, prolapse it underneath the valve and ablate the ventricular end of the accessory pathway. So both transeptal and retroaortic route can be used to ablate these left-sided free wall accessory pathways. The right AV junction, on the other hand, it has a slightly different anatomy in terms of the depth of the groove. The AV groove is much deeper. The tricuspid annulus is also much more floppy, and it's much more mobile than the mitral annulus. So because it's a very deep groove, the atrium and ventricular myocardial are close to each other for a much longer distance. So these accessory pathways can be relatively superficial, whereas the left side pathways skirt the annulus. These are much superficial in the groove, can be much superficial in the groove. And also these tend to be broader pathways. So we usually approach it from the right atrial endocardium. Because of these anatomical differences, because of the broadness of the pathways and the mobility of the tricuspid annulus, the right side pathways are slightly technically more difficult to ablate than the left side pathway. They require more lesions, and also the recurrence rate are also slightly higher than the left side pathway. Coming to the septal accessory pathways, the free wall accessory pathways is simple. You have an AV groove, you have right atrium, left atrium, or the right ventricle, or the other side, and the pathways just skirt across the annulus. Sometimes they can be oblique, but there's nothing much in terms of anatomy. Whereas septal accessory pathways are more complex. The complexity arises because of this anatomical situation. We all know that this the tricuspid annulus is apically displaced compared to the mitral annulus. This is a specimen of from the looking at the heart from RAO angle. The free wall of the right ventricle has been removed. So is the right atrial myocardium. You can see the aorta with the non-coronary cusp posteriorly and right coronary cusp anteriorly. You have the left atrium, and this is the rough plane of the mitral annulus. And you can see that the tricuspid annulus has been left behind in this anatomical specimen. Here we see that the tricuspid annulus is apically displaced. What this does is exposes part of the left ventricle to the right atrial myocardium. So if you see this in a different angle, you can see that this is the non-coronary cusp, this is the right coronary cusp. You have this mitral annulus with the left atrium. You have the tricuspid annulus. So you can see that there is a triangular area of left ventricle over which the right atrial myocardium lies. They're not directly in connection, but it's anatomically proximate. So the point here is, so the pathways in this region can be from the right atrium to the right ventricle along the posterior septal aspect of the tricuspid annulus. Sometimes the pathways can traverse this so-called area. It's called a posterior pyramidal space, where this one of the walls is formed by the left ventricle, the other wall is formed by the left atrium, and the other wall by the right atrium. You can imagine the right atrial muscle sheet overlying this region. So there can be connections between the right atrium and the left ventricle. And also you have a coronary sinus that traverses this space. So there can be pathways that connect the coronary sinus indirectly, which I'll come into a little later. And also there can be pathways in this region connecting the left atrium to the left ventricle. So this is slightly more complex region than the sites which you have seen. So the interesting thing is that we have seen pathways which go directly from the atrium to the ventricle. Sometimes what happens is the coronary sinus is considered as a another chamber. It's embryologically very similar to right atrium. It develops from the left horn of the sinus venosus. It has electrophysiological properties similar to the atrium. So in this picture, you can see that there is this striae represent the coronary sinus musculature. Usually this musculature is contiguous with the atrial musculature. However, this is not continuous with the ventricular musculature. So what happens sometimes is, in some individuals, there can be a aberrant connection between this coronary sinus and the ventricle, thereby forming a indirect connection from the atrium into the coronary sinus into the ventricle, to the left ventricle to be specific. So it just connects the atrium to the CS to the left ventricle. These are called the coronary sinus pathways, sometimes called epicardial pathways in this situation. So you can see the same thing. Sometimes these coronary sinus pathways are associated with coronary anomalies, sinus anomalies. These are like spindle-shaped dilatation. Sometimes they're called, there is diverticulous or aneurysmal dilatations or pouches here. So the point here is we may have to map into this coronary sinus also when you have a posteroseptal type of pre-excitation. Just to summarize this posteroseptal area, you have this region in the posterior aspect of the septum where there can be pathways from the right atrium to the right ventricle, right atrium to the left ventricle, coronary sinus to the left ventricle, or the left atrium to the left ventricle. So when you're mapping the posteroseptal area, these are all the sites where we need to map the right tricuspid annulus, the inferior triangle of Koch, the coronary sinus, the proximal branches of the coronary sinus, and sometimes we may have to go to the left side and map the left posteroseptal region. So the transition between this posteroseptal and higher up, so-called mid or anteroseptal, is there is no anatomical landmark which differentiate between these two. There is an arbitrary division based on for safety concerns. So we usually traditionally take the superior margin of the coronary sinus os as the limit between the mid septum and the posteroseptum. The reason being that it's more for safety reasons. The compact node is above this level in most individuals in the atrial myocardium. So if you're going higher than this level, the risk of AV block increases. So this posteroseptal pathways, as long as you're keeping it lower than the os of the superior margin of the os of the CS or the roof of the CS, it's safe to ablate. Now, the anteroseptal pathways, again, if you see the right side LAO picture, the bundle of His is actually on almost at the crest of the septum. Traditionally, the pathways which were higher than the bundle of His in this region, which were close to the non-coronary cusp, were called anteroseptal pathways, included this. However, you can see that these are actually not on the septum; they are higher up. So a better name nowadays is parahisian accessory pathways, where they so the easy electrophysiological marker is wherever you get a good prominent His deflection in this region and you map the pathway to that region, it's called a parahisian pathways. you can imagine that the pathways in this region, ablation is risky in the sense you're likely to damage the His bundle or the compact AV node. However, ablating from the endocardium has higher risk, but if you're ablating from the non-coronary, you can see the relationship of the non-coronary cusp to this region, the parahisian pathways. It's very close. So ablating from this non-coronary cusp of these pathways has been found to be safer than ablating from the endocardial site. So parahisian pathways can be mapped from the non-coronary cusp. So the region above the level of this superior margin of the CS os and below the level where you get His deflection or the His electrogram is so-called mid-septal accessory pathway. This is probably the most dangerous area to ablate because of the presence of compact AV node. It's even riskier. The highest instance of AV block is in this region. It's even higher than the anteroseptal or the parahisian region for several reasons. One, we don't have a reliable marker of electrophysiological marker of compact node. There's no way to say that, at least in the His, you can say that we are close to the His because of the electrogram. But here we don't have a reliable electrogram of the compact node. So, and also this is very superficial in atrial muscle. And also, unlike the His bundle, which has a fibrous covering, the compact AV node does not have fibrous covering. So its sensitivity to heat is lower than the His bundle. So it has a high incidence of AV block. Here, the idea is to be as ventricular as possible. In fact, other areas we get A and V signal. Here we try to get only the ventricular signal. Or sometimes we may have to prolapse it underneath the septal leaflet of the tricuspid and ablate it from the ventricular aspect. So you have posteroseptal pathways, you have a parahisian or the anteroseptal pathways, and then mid-septal pathways. To summarize, the free wall accessory pathways are the easiest to map and ablate. They have the highest success rate. The left is probably easier to ablate than the right. The posteroseptal accessory pathways are the most complex anatomy. You need to map the right posteroseptal region, the coronary sinus, the left posteroseptal region. And the parahisian pathways, even though the ablation is risky, now we have realized that ablating from non-coronary cusp is probably safer than endocardial side. So even they have the higher risk, have better success rate than mid-septal pathways. The highest risk of AV block is with the mid-septal accessory pathways. So that needs to be kept in mind. Thank you.
Thank you, Dr. Sirish. This is Dr. Kapil Kumawat here. Excellent brief summary of the anatomy. There is a lot to discuss, I can understand. It was an interesting presentation. I wish we could have continued it more, but just to highlight few things, posteroseptal pathway is usually referred to as right posteroseptal or left posteroseptal, whereas in fact, you can approach these areas either from the left or the right most of the times. And second is, Dr. Sirish, I would like to ask you a question. Whenever we are unsuccessful in ablating pathways, we refer to these pathways as probably epicardial pathways. So is there any truth in this thing?
Yeah, I mean, and whenever I have heard experts, all pathways are epicardial. So it's just that. So every pathway is epicardial. So there is no endocardial pathway as such. So it's just the complexity of the anatomy, probably the broad pathways or the stability and other issues or mapping issues, complicated mapping issues. Those are more likely to play than actual epicardially located pathway, which require an epicardial ablation is what we feel. Because put together the combined experience, we hardly require epicardial access to ablate those pathways.
And also in the left free wall region, the left lateral area, sometimes, when we are ablating, we do find that we have pretty good signals, but we are unable to ablate. And do you think anything to do with the anatomy where the coronary, where the left atrial appendage and the inferior pulmonary vein, they come into picture in that region, and you get signals when they're not actually in the annulus and rather in one of those structures, and you keep ablating there and nothing happens. Yeah.
So there are great pathways which have been described to connect from the. So whenever it's in the region of left anterolateral region, it's always wiser to just go into the proximal appendage and see the signal whether it's getting late and then come back rather than ablate and then extensive ablation and then go back, even on the right atrial appendage side.
Yeah. Hi, Dr. Vivek, any comments?
Yeah, I think if you look, even the epicardial pathways, theoretically, even the pathways which are seated inside and embedded inside the coronary sinus are also kind of epicardial only. So one need not go through the subxiphoid process. Even so, a lot of these pathways then are called epicardial if they are part of the coronary sinus process. And absolutely right. And I think we'll cover this later on. But one problem I have found with people who say that they had signals but could not ablate in the left lateral area was a good annulus contact. So remember that you can get far field signals also, and one needs to get good sharp contact with annulus, and then it's a question of reach and other things and access. So yes, practical issues also involve these difficult pathways sometimes.
Just one last comment that you mentioned that when we go retro-aortic, you need to always be under the valve leaflets, but there is another way where you can prolapse your catheter into LA through the valve and then still come from the left atrial side also. In fact, many people find it easier than going underneath the leaflet, because once you are under the leaflet, the movement becomes almost impossible if you want to fine-tune your position.
It gives excellent stability, but again, mapping makes it's very difficult to map in that region. Yeah, I agree that.
So we'll go to the next talk then, keeping the time in mind. And Dr. John, you would like to introduce the next speaker?
Yeah. So, Sirish, if you can just unshare and I'll start sharing my slides. I'm going to be giving the next talk. So good morning, everybody, and thank you for logging into this session on accessory pathways. I'm going to be speaking about localization of accessory pathways on the ECG. So that obviously begs the question as to why do we have to localize pathways in the first place? And the reason we localize pathways is essentially that if we knew exactly where a pathway was most likely going to be, it would help us when we speak to the family with regards to consenting the patient for the procedure and the risks involved. Because if it was a left-sided pathway and we were planning a transseptal puncture, then we would include the discussion of a transseptal puncture with the risks involved. And same way, if it was a right-sided pathway, like Sirish just mentioned, how the tricuspid annulus is quite slippery, you may want to use an extra sheath to position. So the other reason is that it helps in pre-procedural planning as to what all catheters you need, whether you need a transseptal puncture, whether you need a sheath to give you catheter stability based on the location of the pathway. And obviously, if you knew where the pathway is most likely going to be located, it would reduce the time that you would take to do the procedure. So when you look at patients who got accessory pathways, you essentially have the ventricle being activated by the AV node bundle office and the conduction system, and also by the accessory pathway. So there are two ways by which the ventricle gets activated. And when the impulse travels down, it's an ongoing competition between these two ways as to who captures more of the ventricle. So invariably, because the AV node has a slower conduction thanks to its refractoriness, the accessory pathway beats the AV node towards reaching the ventricle early, and hence you have a part of the ventricle that gets activated by the accessory pathway much earlier than the rest of the ventricular myocardium. So this part of the ventricle that gets activated early is what contributes to your delta wave on the ECG. And hence, if you are wanting to localize the location of a pathway, we need to see that part of the ventricle that's getting activated early, and that would help us to know where the pathway was located. So going back to basic electrophysiology principles, now here you have the right ventricle where the right ventricular free wall has been removed, showing you the cavity of the right ventricle, and this is your left ventricle over here. And I've just schematically drawn a left-sided pathway. So when you have a left-sided pathway bringing the impulse down, you would expect this part of the ventricle to get activated first, and the impulse from there to travel on towards the rest of the myocardium. So the vast majority of electrical activation is sort of going to be traveling away from lead AVL or lead 1 or any of the left-sided leads. And hence, because electrical activation is going to be moving away from that, obviously you would expect a negative initial delta wave in these left-sided leads when you have a left-sided pathway. So it's important for us to always look at the early part of the QRS, because that is what is going to tell us which part of the myocardium is getting activated by the pathway. And then when we look at that early part of the QRS and look at the vector and the direction which is getting activated, it would tell us as to where the pathway is likely to be located. So if it was positive, it means current is traveling towards it. If it was negative, current is traveling away from it. So a left-sided pathway will mean that part of the myocardium gets activated early. So the vast majority of current is going to be traveling away from that zone. And so it's going to be negative in the left-sided leads. So like we just mentioned, we need to focus on the initial part of the QRS. But that's always difficult because you can have variable levels of activity of the pathway versus the AV node, and somebody who is having a slick AV node, like is very common in children, you may actually have the pathway conduction completely obscured, and it may make it very difficult to really notice a delta wave and really identify the location of the pathway. So to bring out this pathway activation, you could either do atrial pacing, or you could do an exercise stress test where you sort of stress the AV node and your pathway is conducting predominantly, or you could give adenosine. So these are some ways by which you can bring out maximal pre-excitation, which would thereby tell you how the myocardium is getting activated when it's getting activated by the pathway, and that would in turn help you to localize the pathway. However, having said all this, the algorithms which are being used to localize pathways, which are based on these basic principles, have a lot of problems with them. And the reason why they have problems are because there can be a variability in which the leads are placed from center to center. You can have different body structure, different position of the heart and the chest. There could be structural abnormalities. You can have multiple accessory pathways. And most commonly, your pre-excitation may just be submaximal. Thereby, you cannot really put all your bets on as to how is the QRS vector in the initial part of it. So there are any number of algorithms that you can find in literature on trying to localize accessory pathways. And it's not easy to remember these algorithms. And I, for one, have not been able to actually memorize an algorithm. It's more important to sort of look at the basic principles behind these algorithms. So this is the Aruda algorithm, which is by far generally the most accepted algorithm. But before we actually try to by heart an algorithm, I think it's more important for us to understand the principles. And if we can actually understand the principles, then we can sort of use that to apply our knowledge to every single accessory pathway that we meet. So like Sirish had already covered for you, in this anatomical specimen, you can see that the right ventricle is anteriorly located, whereas your left ventricle is posteriorly located. And the left ventricle is not just posterior, but it is also superior to the right ventricle. So you have a portion of left ventricle that goes all the way high up over there. So you have left ventricular myocardium that is superior to the right ventricular myocardium. Your mitral annulus is located superior to your tricuspid annulus. And as Sirish had just told you, all pathways cross past the annulus. So obviously, left-sided pathways are going to be located higher up than right-sided pathways. They're going to be more posteriorly located than right-sided pathways, and they're going to be more leftward located than right-sided pathways. So these are some basic things to be aware of, because obviously, if you had a left-sided pathway, you're now going to realize that that particular pathway is going to be located superiorly, posteriorly, and leftward. And so that's going to automatically have implications on leads which are placed superior, posterior, leftward, and so on. The other thing that comes through clearly from this is that if your QRS transition happens after lead V2, which is sort of sitting across the septum, then it's very likely to be a right-sided pathway. So the anatomical way in which we documented pathways, like you call pathways being anterior, posterior, and lateral. Now, these are the terminologies that are still in vogue, but theoretically speaking, literally speaking, they're not right. Because if you actually looked at your heart, like we just said, what is anterior is actually superior, and what is lateral on the mitral annulus, like we just saw in this here, lateral, that would actually be posterior. So a left lateral pathway would actually, in real sense, is a posterior pathway. And what we describe traditionally as being posterior is actually inferior. So it's important to be cognizant of this, because these are the terminologies which are in use by everybody. But you should automatically in your mind understand that when they're saying it's a left lateral pathway, they're referring to a pathway somewhere over here, which in reality is actually posteriorly located in the human body. So this is sort of showing you how these pathways are classified. Sirish has already been through it, where you talk about left anterolateral pathways, left lateral pathways, left posterior pathways. And then the septal pathway is being divided into anteroseptal, midseptal, and posteroseptal. And then you have the right lateral, right anterior, and right posterior pathways. But in true sense, it's actually, we're talking about posterior, inferior, and anterior and superior pathways. So the real terminology is different, and it helps to sort of know this because that is what will help you understand how the vector gets activated with regards to the leads that are placed. So essentially, when you're going about looking at an accessory pathway and trying to localize it, the thoughts that should run through your mind are, is a transeptal puncture needed? In other words, is it a left-sided pathway or a right-sided pathway? Having said that, I mean, you can do left-sided pathways going the retrograde route as well. But, you know, this is something that you would need to anyway keep in mind, because there may be a time when you may need to do a transeptal and you need to consent the patient. So deciding if it is left-sided or right-sided is one thing that you first, at the get-go, looking at an ECG, you sort of try to sort out. The next thing you try to sort out is it posteriorly located or anteriorly located? In other words, how are the inferior leads? When we say posterior, we are referring to inferior. Like I showed you over here, this is posterior, but posterior is also, actually speaking, inferior. And your leads 2, 3 AVF are the inferiorly located leads. So if the 2, 3 AVF are going to be negative, then the impulse is traveling away from 2, 3 AVF, and obviously the pathway is going to be inferiorly located or posteriorly located, as the terminology you may use. And then, should the CS be explored is another thing that we have to look at. And is the pathway septal? In other words, do we have to talk about risk of injury to the AV node? So these are the things that we essentially look at when we are trying to localize pathways. So let's start with the left lateral pathways, which, like Sirish told you, is the commonest pathway that we see. So a left lateral pathway is obviously a pathway that's located somewhere over here, which is essentially a posteriorly located pathway. So when you have a pathway located like that, your impulse is obviously going to be traveling away from leads 1 and AVL. And so you are going to have a negative delta in these leads. If you were to look at lead V1, the impulse is going to travel towards it, because V1, as we know, is a right-sided lead. And your R wave will decrease in amplitude on the left-sided leads, because the impulse is traveling, the vast majority of myocardium is going to get activated on this side, and then activate it is this part of the myocardium that gets activated initially, and then the vast majority of myocardium gets activated in this direction. So the impulse is traveling towards V1, giving V1 positivity, and your R waves in the lateral leads, V4, V5, V6, are going to be diminished. And thirdly, if you were to look at the inferior leads, we obviously know that a left lateral pathway is now going to be high up located over here, superior. We said the left ventricle is superior to the right ventricle. So obviously, your inferior leads are going to record positive deflections. So when we look at an ECG here, you can see that it's positive in V1. So its current is traveling towards V1, making it a left-sided pathway. It's negative in 1 and AVL, and your inferior leads are positive. So these are the findings that you would expect to see in a left lateral accessory pathway. Moving on from there to the other extreme is the right lateral accessory pathway. So a right lateral accessory pathway is sort of going to be located over here. Now, when you have a pathway located over here, it is obviously going to be located sort of inferiorly. And so your activation of the inferior leads is going to have an impact. Same way, your left-sided leads are going to be located far away from here. So the vast majority of myocardium is going to get activated in this direction. So you'll have this part getting activated early, and then the impulse is going to travel in this direction. Thereby, your leads 1 AVL are going to record positive deflections. So you'll have a positive deflection in 1 and AVL. And when you look at the left versus right, your V1 is going to be negative, which is a right-sided lead, whereas your V6 is going to be positive. And when you look at the inferior leads, you're going to have negative deflections in lead 3 and AVF. Now, lead 3 is sort of located over here. So obviously, the impulse is going to travel away from lead 3, giving you a negative deflection. AVF is located at the bottom. And again, this is sort of inferiorly located. So AVF is also going to be negative. But lead 2 is sort of located over here. So since lead 2 is located over here, you can have some amount of current traveling towards lead 2, giving a positive deflection in lead 2. So here we have a right-sided, right lateral accessory pathway, where you can see that you have a positive deflection in 2, but 3 and AVF are negative. Your lead 1 and AVL are both showing positive deflections. And in V1, we have a net negativity. So we move on from there to the septal pathways. Now, the septal pathways are by and far the toughest to actually be really sure about. And now the reason I say that is because when you look at anatomy and the way things are located, if something is sort of septally located, it could be anywhere over here, but a pathway that is over here can sometimes be confused with a pathway that is septal. So a right anterior pathway that you would call in traditional connotation can look similar to an anteroseptal pathway. And also you can have how the ECG is being recorded, how the heart is located in the human body. And so these things can actually cause trouble in being really very sure that it is anteroseptal versus right anterior. So in fact, most algorithms, if you look through in the literature, I've had trouble really finding definitive ways of saying that it is anteroseptal versus not being right anterior. However, having looked at that, now when you think of an anteroseptal pathway, it is located right in front and right below the chest wall. So it's all the way in the front. So when you have something like that, your 1 and AVL are still away from it. So impulse is going to travel towards 1 and AVL. So you'll have a positive deflection in 1 and AVL. When you look at the V1 to V3, now they are all anterior leads, and this pathway is also sort of anteriorly located. So you can have negative deflections in V1 to V3 with a positive deflection in V6. And when you look at the inferior leads, you're going to have a positive deflection in inferior leads because the impulse is going to travel from what is anterior to the inferior leads, which are sort of posteriorly located. So you're going to have a positive deflection in your inferior leads. So here we have an anteroseptal pathway. You can see a transition from V1 to V2 here, making it sort of septally located. Your 1 and AVL, which are lateral leads, are having positive deflections. Your inferior leads are also all positive because we're proving that the pathway is anteriorly located. Now, moving on from anteroseptal, which is all the way over here and right in the front, to midseptal, which is a little bit behind. Now, obviously, if a pathway is midseptal, now there is myocardium in between the pathway location and the chest leads. And hence, unlike an anteroseptal where you would expect negativity in V1 to V3, here you could expect some positivity in V1, V2, V3. So here too, 1 and AVL are far away from it, and myocardium is going to be activated from here. The vast majority of the myocardium being left ventricular is going to get activated and pull the vector in that direction, giving you positive deflections in 1 and AVL. However, when you look at leads V1 and V2, you would expect some positive deflection. Like I told you, since the midseptal is located a little behind the anteroseptal, so there is myocardium between that and your leads. And so you can have positive deflections in V1 and V2. And your inferior leads will have a positive deflection as well, because there's a lot of myocardium behind and your inferior leads are located below. So this is how you would suspect the presence of a midseptal pathway. But I would like to reiterate again that anteroseptal and midseptal pathways localizing is not so simple and straightforward as we put it out here. There are multiple other criteria that people have looked at as well to sort of localize these pathways, and nothing gives you 100% sensitivity and specificity towards localizing it.
John, you need to conclude now because we're running out of time.
Oh, sure. Thanks, Vivek. So this is a midseptal pathway here. You have it positive in the inferior leads. You have some positivity in V1 and V2, and lead 1 and AVL are positive as well. Moving on to posteroseptal pathways, which, like Sirish told you, the second most common set of pathways. These pathways are again posteriorly located, so they're going to have positive deflections in 1 and AVL, and they are going to travel away from V1 because they are generally right-sided. So you'll have a negative in V1, a positive in V6, and these pathways are going to be negative in inferior leads very importantly because they are all located in the postero-inferior location. So this is a right posteroseptal pathway where you have a negative in V1 and a positive in V2, a transition from V1 to V2. And this is a left posteroseptal pathway where again you have a positive deflection in V1 and a transition from V1 to V2 with negative in 3 and AVF. Now, like Sirish already told you, the posteroseptal region has the coronary sinus. It also has the posterolateral branch of the right coronary artery, which lies right next to it. And sometimes you can have a bulge over here, which is known as a CS diverticulum, which can have pathways associated with it. So when you have a CS diverticulum with pathways associated with it, you usually have a negative in 2 as well. So posteroseptal pathways don't necessarily have a QS complex in 2, but pathways that involve a CS diverticulum have a QS complex in lead 2. So essentially, when we look at the steps involved, is a transeptal puncture needed? Look at how it is in lead V1 and 1 and AVL to decide whether it's left-sided or right-sided. Is it posterior or not? Look at the inferior leads 2, 3 AVF to decide whether it's posterior. Should the CS be explored? If you have a QS complex in lead 2, then you will have to think of the CS having to be explored in a posteroseptal pathway. And the septal pathways where you have a transition V1 to V2 with the other features that we discussed would make you think that there may be a risk for damage to the AV node. So essentially, remember that the degree of pre-excitation depends on how much of the pathway is contributing to it. So you cannot really put all your bets on that, and always think of the direction of the current vector in the early QRS towards making your diagnosis. Thank you.
So thank you so much, John. This was a wonderful, wonderful lecture, and I really hated to interrupt you in between because I really think that more time should have been given to this particular topic because this is of utmost relevance to any cardiologist for that matter, and pediatricians also. So I think it's very clear that you need a maximally pre-excited ECG for really localizing the pathway in any meaningful way. And the left-sided pathways, obviously, because it's so far away from the central leads, mostly get hidden because of that, because there is a distance. And people have, I would like to ask your opinion about two other things which people say about presence of pathway. One is loss of septal Q waves and one is short PR. So what is your opinion on these two for suspecting a pathway in a person?
Yeah, so the short PR interval is, it's something that you have to be very alert about, because in the pediatric population, the AV node is very slick and you can have PRs which are pretty short. So if you see a short PR interval in a 40-year-old, the implications are different from seeing that in an 18-year-old or even younger age group. So I would be a little cautious in sort of labeling short PR intervals as obviously having accessory pathways. And when in doubt, you could always give an adenosine injection to check or put the patient on a treadmill and see what actually happens. And with regards to the loss of Q waves, I think that is a relevant point to look at. Particularly, I think Dr. Hariharan would touch on that when he's speaking on atriofascicular pathways. So I would leave it to him rather than sort of dwell on that right now.
Thank you so much, Kapil or Dr. David. If you have anything else to comment, we may be sparing 1 minute for that.
Just one thing that underlying bundle branch block sometimes can complicate the ECG assessment, and that always has to be kept in mind.
Very true, very true. Very important point, Dr. Kapil. Thank you for bringing that up.
Yes, so that's absolutely correct. So it might be a problem in the older people as well. So thanks again, John, for a wonderful lecture. And I would like to invite Dr. Anand now for describing the ECG of pre-excited AF and other kinds of tachycardia that happen with an accessory pathway.
Good morning, everyone. I'm Dr. Anand from Christian Medical College. I thank IHRS for giving me this opportunity, and also Dr. Vivek for introducing me. So my session is on ECG features of accessory pathway. So this is, as the heading says, it's ECG features. So it's mainly looking into the basic ECG of accessory pathway with pre-excitation and what is autotromic AVRT, antidromic AVRT, and pre-excited AF. It is mainly for DM and DNB residents. So at the end of the lecture, you should be knowing what are the ECG features of pre-excitation, what is autotromic AVRT, antidromic AVRT, and pre-excited AF. Okay. So take the first scenario where sinus rhythm with no accessory pathway. When the sinus node fires, it activates the right atrium. From the right atrium goes to the AV node. Then from the AV node, it goes to the His-Purkinje system, and it activates the entire LV and the RV myocardium. So the LV and RV myocardium activation is shown in green color. Since bulk of the myocardium is activated simultaneously via the His-Purkinje system, we get a narrow QRS. There is no delta wave, and the PR interval is normal. Okay. Take the scenario where sinus rhythm with the accessory pathway. Here the accessory pathway is present on the left side on the left lateral accessory pathway, which connects the left atrium to the left ventricle. When the sinus node fires, it goes to the AV node. At the same time, it goes from the right atrium to the left atrium, and it goes via the AV node. And at the same time, it's activating the AV node. It activates the accessory pathway And from the accessory part, it goes from the left atrium, left ventricle, and activates small amount of the LV myocardium. As it activates the LV myocardium, it goes through the His-Purkinje system and activates the other RV and the LV myocardium. So the blue portion is the myocardium, which is activated via the accessory pathway. Well, green portion is the myocardium, which is activated via the His-Purkinje system. Hence, the QRS is wide because initial activation is via the accessory pathway, which is muscle to muscle, causing this delta wave, and PR interval is short because here the initial activation is via the left lateral pathway, which precedes the AV node conduction. That's why you get a delta wave with slightly wide QRS. Take a scenario where there's an APC coming from the left atrium, which is close to the accessory pathway than the AV node. So there is preferential conduction via the accessory pathway, and a lot of myocardium is activated via the accessory pathway rather than via the His-Purkinje system. So that is a blue color. It is more area is activated by the blue color, which is accessory pathway, than via the green color, which is the normal His-Purkinje activation. Hence, there is more pre-excitation and you get a wider QRS. Okay. Consider a junctional beat in the presence of an accessory pathway. The junctional beat is usually arises from the junctional region, which is in the AV node to the His region. So when there is a junctional ectopic, it activates the His-Purkinje system early. So most of the myocardium is activated via the His-Purkinje system. While the His-Purkinje is activated, it may go into the pathway, but before the pathway is activated, the entire myocardium is activated by the His-Purkinje system. Hence, in the presence of a accessory pathway, the junctional beat usually will have a narrow QRS with no pre-excitation. So, in a nutshell, when there is a sinus rhythm with a QRS with no accessory pathway, you get a complete ventricular activation via the His-Purkinje system, leading to a narrow QRS, and the initial portion of the QRS is very short because lot of myocardium is activated simultaneously. When there's an accessory pathway, there is a fusion between the accessory pathway conduction and the His-Purkinje system, and the initial ventricular activation via the accessory pathway, which is then followed by the His-Purkinje system. This initial ventricular activation via the pathway leads to delta wave, which is slurred. It is due to slurring is due to the slow conduction via muscle to muscle conduction. Okay, coming to the absence of delta waves on baseline ECG in the presence of an accessory pathway. So there are even though the accessory pathway is present, the baseline ECG does not show any pre-excitation. So what are the causes? The main important cause is concealed accessory pathway. That means there is absent antegrade accessory pathway conduction. There is no A to V conduction via the pathway. The pathway conducts only retrogradely via V to A. Then other causes are like slow antegrade accessory pathway conduction relative to the AV node. Here the AV nodal conduction beats the accessory pathway conduction, thereby there is no pre-excitation. And very rarely left lateral accessory pathway. This is because left lateral accessory pathway is in the far away from the SA node to the AV node. So the ventricular activation preferentially via the AV node, as it is more near the right side of the septum to the sinus node. Coming to the next one, accessory pathway related tachycardias. There are three important tachycardias. Like one is autotromic AVRT, then is antitromic AVRT, then is pre-excited tachycardia. That is any SVT where pathway is a bystander. It can be AVNRT or AVRT with bystander pre-excitation, atrial tachycardia with bystander pre-excitation, or a pre-excited AF. And finally, there's a pathway to pathway tachycardia, which is usually very rare. So this is how autotromic AVRT usually gets initiated. When there is a normal sinus beat or a paced beat, it goes to the AV node and also via the accessory pathway to the myocardium. So what is shown in red color is the muscle myocardium, which is activated via the AV node His-Purkinje system, while the yellow color is via the pathway. So you have pre-excitation. When there is a beat, which may be an APC or an timed beat in such a way that it goes to the AV node and also goes to the pathway, but it finds a pathway refractory. Hence, the entire ventricular activation is via the His-Purkinje system. So you get a narrow QRS with absent pre-excitation. This, after this is activated, left bundle to the left side, of the lateral free wall, it finds the accessory pathway outside of the refractory period. So then now the accessory pathway is able to conduct retrograde from V to A, and it activates the atrium and initiates the re-entry circuit. So in the autodromic AVRT, it is a narrow QRS tachycardia because it is the myocardium is active via the AV node to the His-Purkinje system. Here the antegrade limb is the AV node and the retrograde limb is the pathway. Since its AV node is antegrade limb, it is a adenosine sensitive tachycardia. It's a short RP tachycardia because from A to V it goes via the AV node, which is low conduction. From V to A it goes via the pathway, which is usually regular accessory pathways or fast conducting pathways. And again from A to V it goes via the slow AV node, V to A via the pathway. So you can see that the AV, from this you can see that A to V it takes a longer time, while from V to it takes a short time. So it's a since VA interval is shorter than the AV interval, it's a short tachycardia. This is an ECG of a patient showing pre-excitation in the baseline with a positive R in V1 and negative delta wave in 1 and AV, such as left-sided accessory pathway. This patient had a tachycardia, and during the tachycardia, you can see it's an narrow QRS regular tachycardia. There is no prominent R in V1. There is no delta wave. There is no pre-excitation during the tachycardia. So absence of pre-excitation is more in favor of an autodromic AVRT. Well, when you closely look at the inferior leads 2-3 AVF, you can clearly see that this is the ST segment. In ST segment, there is a bump here, which is constantly seen in 2-3 AVF, which is this bump is due to the inverted P waves, as the P wave is due to retrograde atrial activation. So it is invert the negative P waves in 2-3 AVF. In AVRT, there is sequential activation of the from the atrium to ventricle, then to ventricle to atrium. So first the ventricle is activated, then it activates the atrium. So that RP interval in AVRT is usually more than 70 milliseconds. That is in favor of AVRT when compared to AVNRT. And there is another subtle sign is that since a negative P wave, it falls on the ST segment, it drags the ST segment down, causing a ST segment depression. So presence of ST segment depression in narrow QRS tachycardia is in favor of AVRT. This is not a hard rule. It's a soft sign that if the tachycardia has a ST segment depression, it is a AVRT. But most robust is that if it is more than 70 milliseconds, it's in favor of a autodromic AVRT using a regular accessory pathway. Now coming to the antidromic AVRT. Here the circuit is just a reverse of the previous one. Here the circuit is antegrally from the A to V via the pathway. It activates the myocardium. From the myocardium, then it engages the His-Purkinje system and retrograde via the AV node. And from the AV node, it goes against the atrium. So this is the circuit here. You can see the antegrade limb is accessory pathway and the retrograde limb is the AV node. You can see that the ventricular activation is initially via the pathway. Once His-Purkinje system is activated, it goes via the right bundle, then the left bundle is activated, and the LV is predominantly activated via the His-Purkinje system. This is again AV node dependent tachycardia. There is so in a patient with an antidromic AVRT, pre-exit tachycardia, if there is a VT, focal VT or a VT exit site is in the same region, then the activation of the ventricle is also in the same way as that of doing antidromic AVRT. So based on the QRS morphology alone, we cannot clearly difference between an antidromic AVRT and a VT arising from the same region, focal VT or a exit site is in the same region. This is a ECG of a patient who has a structurally normal heart. There's a white QRS tachycardia, which is regular. It's of a RBB in morphology is prominent R in V1. There's a negative in 1 and AVL, such as a left-sided accessory pathway. This patient during the sinus rhythm did not have any pre-excitation here. It is due to the left-sided accessory pathway, which is far away from the sinus node. That's why during a normal sinus rhythm ECG, you can't see pre-excitation because his AV node conduction is brisk and most of the QRS is activated by the AV node. So another most important thing is the pre-excited AF. We all know that the AF is a chaotic rhythm going on in the atrium. So since it's a chaotic rhythm, it bombards and AV node and the accessory pathway at different times and makes them partially refractory. So because of that, sometimes the AV node conduction is brisk, sometimes the accessory pathway conduction is brisk. So in the left side heart diagram, here the accessory pathway conduction is more brisk while AV node is sluggishly conducting. So that the QRS is predominantly via the accessory pathway and less via the AV node. In the second right hand of the diagram, here the accessory pathway conduction is less while the AV node conduction is more brisk. So QRS here is more in from AV node region, while from the accessory pathway is less. So in a pre-excited AF, you will have the typical irregular rhythm, white QRS rhythm, and you will have usually have varying degrees of pre-excitation. So this is a ECG. You can see that irregular rhythm, so this is favor of VT. It's not in favor of VT. As you can see, it's very irregular. This amount of irregularity you can't see in VT. And you can see that the QRS is not typical of any bundle branch block. It's more in favor of a delta wave in V1 and also in 2-3 AVFs. So it's a pre-excited AF involving a left lateral accessory pathway. This patient, again, during a sinus rhythm, you don't see any pre-excitation as it is in the left lateral, which is far away from the sinus node, and the preferential conduction in this patient is via the AV node. This is another patient with showing a baseline pre-excitation. Again, it's a left lateral pathway. It's you can get the prominent R in V1 and negative in AVL. And again, during AF, you can see that the irregular rhythm with a suggestion of a pre-excited AF. So that's all. I once again thank the IHRS for giving me this opportunity. Thank you.
Since we are short of time, a few comments only. And the first one is there a way to identify antidromic tachycardia from ventricular tachycardia?
Based on the ECG, if you can show a VA dissociation, then that's the most important factor with differentiating between antidromic VT and VT. And other than that, other than the pre-exit, AV dissociation, based on ECG, we can't clearly see. There's no way we can differentiate between the two.
Yeah, very true. That's why it's very important to fish for any available ECGs from the past. And also the clinical scenario you have to keep in mind. Younger patients, no comorbidities. You would think also about this antidromic tachycardia when you see a white QRS complex tachycardia. But in general, antidromic AVRTs are pretty uncommon. And we rarely do find them in clinical settings, though we do induce them in lab many a times. But in general, presenting with antidromic tachycardia in emergency or in OPDs are pretty rare, isn't it, Dr.
Yes,
Vivek?
I think you're absolutely right. It's more of a lab thing than, but yes, we do see it uncommonly, and when we see it, it's important to recognize it for what it is. Dr. David, do you have any comments to make about this?
Yeah, it depends on how quickly the conduction system is getting activated during the VT. It may produce a very sharp deflection if it is pretty close to the conduction system. That may help as well. Whereas in the pre-excitation, it would be a cell-to-cell conduction. The delta wave may be a guide, but in the presence of an epicardial VT, it would be difficult to tell.
Yes. So anyway, Dr. David, you be online and start presenting your presentation, because it's time that we, catch up with the lost time. Thank you.
Thank you, sir.
Are my slides visible?
Not yet. You still can't see your slides, sir.
Okay. What about
Ah,
now?
it's coming. It's coming.
Now it's there. Now it's there.
Excellent. Happy morning and maybe even afternoon to all those present. Thank you to the organizers for giving us this opportunity.
Sir, I think we are able to see only the presentation mode of your slides, not the actual presentation.
Okay, I'll just go back to that.
I think you'll need to go to the display settings or something.
How about now?
We are still seeing the presenter mode actually, not the on-screen mode. Yeah, you can. Yeah, now it's better. Sir.
Better? Yeah, thanks for that. Yeah.
Just go to the slideshow, sir, at the bottom.
Is that visible? Because I can't see the.
No, it's not come yet. Yeah, now it's come. It's come.
Okay, there's a lag. Yeah. Okay. So we are ready to go now.
You could just choose the laser. Yeah.
Yeah.
Perfect.
Okay.
Perfect, sir.
Thank you all for this opportunity. Thank you to the organizers as well. The next 10 minutes or so, I'll be trying to get a picture of what we try to do in the lab. It is more going to be a snapshot kind of a thing rather than in detail kind of evaluation. What happens in the cath lab is what I'm going to be dwelling on. The important thing to highlight now is we are talking about pre-excitation. In WPW syndrome, if there is pre-excitation, that is antegrade pre-excitation. If someone has orthodromic AVRT without obvious pre-excitation on the 12 DCD, and if it is proven to be orthodromic AVRT, that means there is no manifest antegrade conduction from the atrium into the ventricle through the pathway, but there is retrograde conduction from the ventricle back into the atrium, which is contributing to the circuit of the tachycardia and resulting in a AVRT, atrioventricular oriented tachycardia. So there again, we are seeing pre-excitation in the atrium. So we're talking about either atrial excitation followed by ventricular pre-excitation or ventricular excitation followed by atrial pre-excitation. Fortunately, all of us have an AV node which conducts antegradely and allows us to have normal AV node conduction. And in a person who's got pre-excitation, he could be having parallel conduction happening between the atrium and the ventricle. We have this tracing which shows atrial pacing happening in the right atrium, which results in an atrial depolarization manifest by the atrial EGM seen on the HRA channel, on the proximal HIS channels, and in the CS channels. That is followed by a slightly wide QRS complex with the possible delta wave. And probably the ventricular activation is happening from the right ventricle to the left ventricle, because on the CS channel, which is in the AV groove, we may be able to show ventricular activation happening towards the lateral part of the atrium, lateral part of the mitral annulus, if the catheter has been positioned properly. Anand was talking about premature beat. We try to create artificially premature beats. When we do an EP study, we run a drivetrain in programmed electrical stimulation, which is called, and we give an extra premature stimulus. So the drivetrain is at 600 milliseconds, which is about 100 beats per minute, and we get a premature stimulus in the atrium, which is resulting in a ventricular activation. So the point to understand here is atrial activation is followed by ventricular activation, and this is ventricular pre-excitation. With the premature beat, there is more pre-excitation happening. So we do this programmed electrical stimulation by progressively decreasing the interval between the drivetrain beat and the premature stimulation. And in this case, 600-300 coupling interval allowed little more pre-excitation than was evident in the 600 cycle length spacing. And when we decremented by 10 milliseconds, when we went to 600 to 90 on the right panel, we see atrial activation has happened, but ventricular activation has not happened. What it does tell us here is that that premature beat was able to block in the pathway, and hence there was no ventricular activation happening after the atrial depolarization. Whereas in the left panel, we do see atrial depolarization is followed by a ventricular depolarization. We are not sure whether the AV node is able to conduct as well. It's possible that there is a His spike hiding in here. It's possible, but with such a short decrement from 300 to 290, it would be fortuitous to block both the AV node and the accessory pathway. So the point to be identified here is, before even demonstrating AV node conduction through the pathway, AV node conduction, we were able to show block between the atrium and the ventricle. And here it's presumed that the AV node has got blocked probably previously. Pathway was conducting till this level, and at this point, pathway is not able to conduct. If we do the same thing in a slightly different way, where we are pacing in the atrium rapidly, here we have a patient who's having atrial pacing in the HRA channel, which is showing atrial capture for every beat that is demonstrated on the 12-lead ECG as a QRS complex, which is clearly evident, with a wide complex. So atrial pacing producing a wide QRS. If it is not pre-excitation, it has to be an aberrant conduction. Okay, so here the rhythm is driven by the atrium. Atrial capture has occurred with a ventricular event happening straight after the atrial capture. With an AV delay, we can make out the A to V interval of 97 milliseconds on the left panel, while pacing continuously at 340 milliseconds cycle length. When we step up, when we decrement the atrial pacing interval from 340 progressively down to 260, we find that the AV interval has increased, but we are still seeing a wide QRS beat, and we are still finding that it is able to conduct from the atrium into the ventricle and producing a wide QRS beat, but abruptly atrial capture continues to happen, but ventricular depolarization has not occurred for these two beats. Subsequently, there is one beat where there is atrial capture followed by a His bundle electrogram, which is clearly evident there as a small deflection which is there, and narrow QRS, which is seen here. So that tells us these beats were pre-excited beats. At this point, both AV node and pathway were blocked. And at this stage, the pathway conduction still remains blocked. but the atrium has captured and resulted in AV node conduction happening. So this tells us that at this rate, the accessory pathway is not able to conduct beat to beat. Even the AV node is not able to conduct, but intermittently the AV node is able to conduct. So I talked about atrial pre-excitation. Without going to the nuances, the actual arrhythmia or tachycardia or accessory pathway, which was evident for the previous slide, I would like here now to point to another aspect without going to actually what's going on there. So I talked about atrial pre-excitation causing ventricular pre-excitation. Now I want to point to the same patient's ECG, which shows a relatively narrow QRS. We can see a his spike there, and there is a ventricular event here, ventricular depolarization, followed by atrial depolarization. I want to highlight that for this beat, the his channel atrial EGM follows the ventricular EGM. The sharp deflections here are the atrial EGMs on the first beat, which are seen as sharp deflections after the ventricular event. And that is the earliest event when there is a ventricular premature beat. That tells us that retrograde conduction is probably happening to the node because it's so close to the V, and because it's close to a channel which is showing a His bundle electrogram, it's probably conducting back up to the ventricle into the atrium to the conduction system, normal conduction system. And when we look at further on this tracing, we find here that there is a delay between the ventricle and the atrial depolarization. This still again is showing as the earliest in the His channel. It is important to identify whether retrograde conduction is happening, which is going to be important to decide, and whether in a concealed accessory pathway, the retrograde conduction is happening from an accessory pathway. So when we do an EP study, we look at the 12-lead ECG. There is subtle evidence of pre-excitation in AVF. V2, there is an incomplete right bundle branch lock pattern in V1, and the HV interval is normal, 56 milliseconds. Normal HV interval is upwards of 55. Anything shorter than that, we'll start wondering whether there's anything happening there. So what do we do in the cath lab? We put catheters inside the heart. Here is one image from a slide RFO view showing a quadripolar catheter in the AV junction. We would expect the AV plane to be here. Assuming they have all gone up through the femoral vein, this catheter should reach the AV junction there. The next catheter should cross across the AV plane into the RV. This catheter has shot across from right to left through the coronary sinus towards the other side. And this catheter is somewhere lower down, probably close to the right side annulus. So in one view, you may not be able to tell everything, but it's important to know that if we have catheters at a particular position and we see local ventricular EGMs such as what we are seeing here on the His channel or in the atrial channel, and we find evidence of pre-excitation, either during atrial premature beats, whether they occur spontaneously or because of pacing, followed by ventricular pre-excitation, and we find it happening earlier in the V, and it's happening earlier in the left ventricle, we know it's a left-sided pathway. Happening earlier in the right ventricle, we know it's the right-sided accessory pathway. Or whether in the retrograde direction, while pacing or during ectopy, we are able to show retrograde conduction happening. Instead of going to the normal retrograde conduction through the node, going through an accessory pathway and pre-exciting the left atrium, we may be able to see the atrial electrograms getting activated in the CS channel earlier than in a channel which is close to the AV node. Further, we put catheters close to the spot where we think there is pre-excitation. If we are trying to ablate for a pathway which is causing pre-excitation in the ventricle, and we know there is retrograde conduction happening through the pathway as well. And if we can show during atrial pacing, we're able to capture the ventricle and we're able to go to the earliest V in a pre-excited complex, we might hit the area where the accessory pathway is connecting the ventricle. Similarly, retrogradely, if we pace in the ventricle and look for atrial EGM, if we go to the earliest atrial EGM, we may be able to identify where the pre-excitation is happening from, and we may be able to document that arrhythmia. We may be able to ablate there and block that pathway. In this ECG, I have shown pacing stimulus happening in the RV. There's RV pacing happening, and there's a atrial activation happening in the CS earlier than it can happen in the distal. And we have a catheter placed at some location. In this instance, this is the catheter which is able to identify that there is a ventricular EGM and an atrial EGM, and they're almost so close to each other that you cannot separate between them. You have to stop pacing and see whether there is a separate atrial event and a separate ventricular event at that time, then reconfirm. But that tells us that this is the location where atrial pre-excitation is happening as a result of ventricular pacing. So both are the methods used. If we want to show retrograde pathway conduction, we use RV pacing, or if we want to show antigrade pathway conduction, we use atrial pacing. And sometimes we may have to use atrial pacing close to the pathway if we are not able to overcome the very rapid conduction and activation through the normal conduction in the atrium, which results in atrial excitation before it can reach a pathway, which probably is slightly lateral in its location and inferiorly close to the annulus. In that situation, we may have to pace close to the atrium to get ventricular activation. So those are the nuances of what we do in the lab. So here we have a situation where we have pace in the atrium at a drivetrain of 600 milliseconds. And we have shown that this conduction is happening to the node, atrial event, his bundle activation, ventricular event. All of these happening in a sequence tell us this atrial pacing resulted in a ventricular event with a similar right bundle morphology, but there is no pre-excitation here. So if this happened as a result of ablation, we could say we have been able to get rid of the pathway conduction. But if it is just because of rapid conduction where the AV node has not yet blocked, but the pathway is already blocked, we would be able to say that probably at that point we're not able to see. But this is what we look at. What is the atrial EGM and the ventricular EGM in normal rhythm doing? What is it happening when there is a premature beat? So we might have.
Keith, we'll need to wrap up now because we're running short of time.
Sure. So this is a situation where we have a tachycardia happening with atrial pre-excitation happening close to the CS pause. His channel activation is late. So this is the opposite of what we showed earlier. I'll use this as my final slide just to quickly say that if somebody has got atrial pacing continuously happening, such as I've shown you in the first slide, I've shown only half of this to start with, where I showed that atrial pacing has resulted in ventricular pre-excitation, and the fourth beat, atrial paced event has not resulted in a ventricular event. Subsequently, the AV node has recovered intermittently, and we have a beat which is showing partial pre-excitation, which is a fusion beat between AV node conduction as evidenced by the his bundle electrogram seen there, and the QRS, which is different from this purely narrow when pre-excited type of a QRS, and it's between the more pre-excited beat and this beat. It is somewhere in between. This tells us that this is partially connected, and this is the beat non-phase sinus rhythm. And if we look at a ventricular event, which is followed by an atrial event, that will tell us whether or not there is atrial pre-excitation. Thank you for your attention.
Thank you so much, Dr. Chase, for a very lucid and very detailed, concept building exercise of features of accessory pathway in the EP lab. Could you also tell the trainees a little bit about the utility of accessory pathway potential in locating these pathways in the lab?
Sometimes we are able to see a very sharp deflection between the atrial and ventricular PGM. And if we can see a sharp deflection, that may point to where the pathway is. And a lot of times we may see a potential in a particular area. The ventricular EGM may not be the earliest there, but ablating there surely gets rid of the pathway. And after the pathway is ablated, the potential is no longer seen. So being able to see a potential either between the V and A EGMs on the ablation catheter, or in the other scenario where you are atrial pacing and seeing the ventricular event happen later, you may see between the A and the V. So here this is pacing the V, you may see it between the V and the A. That would be evidence of a pathway conduction depolarization resulting in a potential.
Thanks. And I think that although it's probably not strictly with the EP features of the lab, but it's well to remember that the positioning of the distal CS may be atrial, ventricular, or on the AV groove. So one cannot be totally going by the CS signals. One has to look at the endocardial signals also. And Dr. Kapil or John, you have anything else to comment on this?
Just one quick comment that the signal amplitude, the A versus V, also changes with V pacing and sometimes with the onset of tachycardia. Sometimes what you are seeing in sinus rhythm may not be exactly the same ratio of A and V signals when the tachycardia ensues or you start pacing the ventricle.
That's right. Yeah. Absolutely correct. And that, in fact, even, again, sometimes trainees get confused, but the CS signals changes also depending on from where you have placed your CS. So, when you put it from the neck, it mostly hugs the floor, and when you put it from the femoral, it usually hugs the roof, and so the A and V ratio changes there. So, John, you would like to comment something on this?
No, I agree completely with you, Vivek. Obviously, when we put it like what you said, from the femoral end, it generally hugs the roof, and so you have more prominent A signals than if you went through the jugular.
For the sake of time, we'll finish this here. Thank you so much, Dr. David. And I would like to invite Dr. Javed to speak on something which is still very contentious and how to deal with an asymptomatic WPW.
Good morning, everyone. Can you see my slides?
Yes, we can see your slides. Please go ahead.
Yeah. As the sir already pointed out that this is very contentious, so I won't go into that area. I'll try to sort of summarize it for the general cardiology, for the general cardiology practice. Just a second. So in my presentation, I'll be talking about the risk estimation of sudden cardiac death in WPW pattern, which of course are asymptomatic, means they don't have any symptoms suggestive of any palpitations or any syncope. So typically, these will be the patients referred to cardiology in view of the ECG abnormalities of pre-excitation. So then I'll be covering non-invasive markers of sudden cardiac death and invasive markers of sudden cardiac death. So I'll just touch about the data regarding risk stratification, and finally we'll come to the guidelines on which we all agree now. So first thing is, why does it matter actually? So as was pointed out, there is a risk of sudden cardiac death in patients with asymptomatic pre-excitation. So it is to the tune of about 3 to 4% lifetime risk. Just want to highlight it. It's a lifetime risk, not the annual 3 to 4%. So most cases of sudden cardiac death occur between age 10 and 40 years. And we see most of the patients who come very, in the after 40s, they usually are at low risk for sudden cardiac death. And life-threatening events, unfortunately, can be the initial manifestation in some patients with asymptomatic WPW on ECG. Before going further into this topic, I just want to highlight this kind of ECG. Sometimes we get this kind of ECG where we know there is a pre-excitation, but this pre-excitation is very minimal, but we know it's the pre-excitation. So we should always keep in mind that fasciculoventricular pathway type of pre-excitation is always something we should think about. And in a very interesting study done in China, there were about more than 41,000 patients, school-going children, and who were screened with ECGs for this pre-excitation. So they found about 32 cases. They found 32 cases of WPW, and they subjected all of them to adenosine testing to differentiate the true AV pathway versus fasciculoventricular type of pre-excitation. So what they found, the type B, which means the pre-excitation, what was previously classified. So these will be in modern classification systems. Most of these pathways will have the right septal kind of thing. So among these pathways, I have some glitch in the screen, just trying to figure that out. Yeah. So among the type B pre-excitation, mean septal type of pre-excitation, a predominant majority, that means 23 out of 24, actually were fasciculoventricular type of pre-excitation. So how do we differentiate for the sake of students? Fasciculoventricular type of pre-excitation will persist on AV block or on junctional beats, because this fasciculoventricular is inserts from the fascicle from the His bundle to the, it's below the AV node. So how much exactly is the risk of sudden cardiac death in patients with asymptomatic WPW? This was one large meta-analysis which looked at all the data about sudden cardiac death, who had reported sudden cardiac death in prospective studies. Unfortunately, all of them are just observation studies. So this was published in 2012. 32 studies were picked up for the inclusion in this meta-analysis. What they found that there were 20 sudden cardiac death events, and 6 were, as you can see, 6 were in the children and 14 were in the adults. So the overall event rate, that's sudden cardiac death was 0.86 in adults per 1,000 patient years. This is in, and while as in children it was comparatively much higher. It was 1.93. We can see there is definitely a risk of sudden cardiac death. It is there. It is significant, but it is very, very minimal. And just surprisingly, more some deaths. Majority of these deaths were reported in Italian studies. So all of these patients were asymptomatic. So it's not just the sudden cardiac death. Then there was another study. People looked at, what about the life-threatening events? So patients who have aborted sudden death, or who present with hemodynamic instability, either with AF, with pre-excited AF, or who had syncope. So they tried to look at these patients, at these cases, and compare them with control. They tried to figure out whether we can differentiate this cohort of patients who present with life-threatening events as compared to just controls who had just asymptomatic pre-excitation on the ECG. What they found was that whenever these patients were subjected to EP studies, they found that the patients who the cases compared to the control, they had significantly, shorter accessory pathway effective refractive period, as I can put less than 250 milliseconds. And SPERI, I'll come to it a bit later. SPERI means shortest pre-excited RR interval. So which essentially gives us some idea about the functional, conduction property and the functional refractive period of the accessory pathway. It was significantly shorter in patients in controls. Shortest paced cycle length was, on pacing, the shortest conducted RR interval, that was also significantly shorter in patients who had present with life-threatening events and patients who had any of these events. Okay, they were significantly much higher clubbed in cases compared to control. But there's a problem in this risk estimation. As you can see from on these diagrams on the left. Yeah, so there's some small overlap between cases and controls. That means there are some controls who have not presented with any of the life-threatening events, yet their EP characteristics of the pathways, they come in this zone. They are sort of outliers in this group, in the controls. So this is something we have to be cognizant about. This is something we should know prior to recommending anyone ablation. So in all these studies, what are the clinical high risk features that were found to be associated with sudden cardiac death? Where male sex and WPW, which is detected in the initial 2 decades of life, patients who have a history of AF, or patients who have a syncope. So they will not be essentially asymptomatic, but sometimes some syncopes you won't be sure about whether they are related to the this pre-excitation, or they are just there, just a vasovagal type of this thing. But anyone who presents with syncope, it should be taken as a high risk feature. Patients with congenital heart disease, they have found patients with Ebstein anomalies, they have high risk features. Patients who have familial WPW and high risk occupation. High risk occupations, actually, the risk at stake is much higher compared to the individual risk. So all these patients should be taken as high risk for sudden cardiac death. So what are the non-invasive ways to estimate the sudden cardiac death risk in patients with WPW? It's intermittent pre-excitation. So intermittent pre-excitation, if you see on the same ECG or on the Holter that the pre-excitation in between just comes and goes, so you know that this pathway FRP, functional refractive period, is essentially very long. So it points out towards that, and it has been found out that this is something associated with very low sudden cardiac death. However, there are again some controversial studies where they have found that this may not be the true indicator of low risk, but practically, in the society guidelines, and so far we assume that intermittent pre-excitation is basically a low risk for sudden cardiac death. So then another very useful way to risk stratify these patients will be treadmill test. So what we do in treadmill test, we look for abrupt loss of pre-excitation. So if there's an abrupt loss of pre-excitation, that means we have reached to the functional refractive period of the pathway. That means beyond that, pathway is not able to conduct that path. So that gives us an idea that even if there is AF, even if this pathway won't be able to conduct past beyond this heart rate. So that is an indicator of low risk indicator for sudden cardiac death. Whereas but a practical problem with treadmill test is many times you see gradual loss of the excitation. You are not actually sure whether this is the pathway, whether it got blocked, or whether there's some sort of competition going on between AV node and the pathway. So while on increased grades of exercise, the AV conduction properties, AV conduction increase, so there's a brisk AV conduction and the pathway doesn't get a chance to conduct. So that may be the cause of gradual loss of pre-excitation. So if there's a gradual loss of pre-excitation, we cannot basically stratify that pathway. We have to look for the other test, which we can come later. If you can see on this ECG, the black arrow is already there. So you can see, if you see the lead 3, you can see a nice Q wave. It's pre-excited beat, and the next beat, this PR prolongs, and this Q wave is not there. So there's abrupt loss of pre-excitation. So it's very important, in treadmill tests to find out the leads which have the nice pre-excitation. Say for example, if you lead at V6, it's a bit hard to know where it actually pre-excites. So something of practical importance. On the right side also, you can see nice sudden loss of pre-excitation. So here we know this is sudden loss of pre-excitation around 380 milliseconds. Sorry, around 400, more than 400 milliseconds. So this will be an low risk indicator for sudden cardiac death in this patient. So as I was telling you, there are some data which have looked into this intermittent versus intermittent pre-excitation versus continuous pre-excitation, sudden abrupt loss of pre-excitation on Holter, while compared to gradual loss of pre-excitation on Holter. As we generally believe, these are low risk features. So far, majority consensus is that this is a low risk feature only. But there are some studies which have tried to look deeply into these studies to see whether they are really, whether we can rely on them. So they have found that some conflicting data. But as you can see, people who had pre-intermittent WPW on ECG, they still have AP block cycle length of 240 milliseconds, and people who had sudden loss of pre-excitation, they still had AP block cycle length of 220. But the thing is that these are observational studies, and the inherent problem in risk estimation of sudden cardiac death in these patients is basically sudden cardiac death itself is a very very small magnitude. To see whether to pick up those patients where we have definitely, it's very difficult. So the numerator in estimation of sudden cardiac death in itself is very difficult to estimate, because we cannot identify all sudden cardiac death patients and ascribe it appropriately to this pre-excitation. And the denominator, the population at risk, we actually are not sure about that also. So that is the inherent problem in SCD estimation in these patients. So we should not get confused with this data. So let's focus on that, on something which so far all the consensus statement and the guidelines talk about. So now coming to invasive risk stratification. So people in whom we are not able to risk stratify on non-invasive tests. So for such patients, risk stratification has to be done by invasive testing, which is electrophysiological study. It has been found that SPERI, which is the shortest pre-excited RR interval. This is the SPERI, means once you induce AF, what is the shortest cycle length between two RR intervals? So that gives us an estimate of the conduction velocity of this pathway. If this is less than 250 milliseconds, it is an indicator for sudden cardiac death. It has a very high sensitivity, unfortunately very low specificity of 35% only. And there's a surrogate for SPERI, that is SPERI on atrial pacing and accessory pathway effective refractory period, that also can be included in the sudden cardiac death estimation. And then there is something about isoprenaline testing. There's again controversy whether we should do EP testing on the isoprenaline or not. People who do isoprenaline, they say that basically it tries to mimic the peak exercise once you give isoprenaline testing. So the guidelines are like silent about this. So you should do as per the individual cases. So the problem with this EP study is that sometimes these markers like SPERI, what I talked about, they can sometimes vary in a single study also from time to time. So you have to take into consideration the shortest SPERI that is there in a study. And regarding timing of EP study in children, again, that is some gray area. So generally, people believe that once people who are children who are totally asymptomatic, we can wait up to say previous guidelines would say up to 8 years, or up to up to a body weight of until they achieve a body weight of 15 kgs. That is the consensus that we have so far.
But Javed, we'll need to wind up now because
Yeah.
we're running short of time.
Yeah. I'm just going. This is the consent. This is the guideline. So they say if on baseline electrocardiogram you see manifest pre-excitation, you subject the patient to a TMT. If there's abrupt loss of pre-excitation, this is a low risk for sudden cardiac death. If you are not sure about this, you subject the patient to EP study. If on EP study you have SPERI more than 250, So you can follow him in cardiology with counseling regarding the future symptoms and STD estimation, which is very low. If some people with high risk characteristics or as per the patient choice, you may still consider for ablation, but it's class 2B. And people who have very short Sperry, less than 250, you should discuss the risk and benefit of ablation and appropriately time them for ablation. So that's it. So the take-home message from this presentation is subtle pre-excitations on ECG with no symptoms. The first thing you should always think is fasciculoventricular pathway. So asymptomatic WPW are at increased risk of sudden death by a small yet significant margin. And treadmill tests showing sudden loss of pre-excitation and intermittent pre-excitation are low risk markers for sudden cardiac death. And Sperry less than 250 milliseconds during AF1 EP study has been associated with high risk for sudden cardiac death. And a shared decision making regarding ablation should be done in asymptomatic patients with high risk features. Thank you for patient hearing.
Thank you, Dr. Javed. Very, very lucid presentation. Very, you have highlighted the data very nicely. But there are still questions remaining, which you also highlighted. Which are the patients you would take up for EP study even when they are asymptomatic?
Yes, sir. That's why all patients who are asymptomatic, particularly if they are less than 40 years of age, all such patients actually should be subjected. We, in our practice, actually, we always look for treadmill tests. If we find clear-cut abrupt loss of pre-excitation, we generally counsel the patient and we don't proceed further. But if there is no clear-cut loss of pre-excitation, we always discuss with the patient, and then we go ahead with the EP study to look for high risk features. And this is something we should always discuss with the patient, and which is our practice over here. So those are the patients where we are not able to show low risk features and non-invasive. Those are the patients we subject to EP study.
And when you do EP study in such patients and find the Sperry or the pathway ERP more than 250 milliseconds, say 280 milliseconds, do you leave them as such, or do you still go for ablation?
No, sir. We most of the times we leave them as such, but we have come across some patients. They are they are so much sort of hysterical about this. So we have done some patients who had low risk features. Sometimes we come across such patients, but majority will leave alone there only.
Yeah. So I asked you this question just to highlight this issue, as to we are not always going by what the evidences say, and many times our decisions are influenced by what the patient believes or patient wants, and we also influenced by the location of the pathway. If we believe that the pathway is a juicy, nice, low-hanging fruit, we go for the ablation, even if the pathways are not very rapidly conducting and no high-risk features are there. So it is a gray area. And I think I would invite comments from Dr. David, Dr. John, Vivek also, as to how do you implement these evidences in your practice?
I will say if there is a possibility of safely doing an EP study, the threshold should be lower than in a situation where the facility for doing and monitoring these patients is very difficult. I say this because it's possible also even to do a trans-esophageal type of an EP study if really it's necessary to figure it out. The indication, all of those are can be discussed at a different point. But important thing is when necessary, if possible, we can do it, especially in special groups like patient candidates who are for going to be training for commandos jobs in the armed forces, pilots. They might want a good ECG before they can be taken forward in their training. In that type of situation, even if they're asymptomatic, it may be worthwhile doing an EP study. In other situations, we would be cautious about putting a patient through invasive EP evaluation approach.
Yeah, I think I completely agree with the speakers and the moderators also. I practically have found that high-risk professions like pilots, defense forces, railway locomotive drivers. Practically, you end up offering ablation to all of them, because how much ever you try, and I've tried, nobody accepts them into these forces or into a flying job unless they have a normal ECG. So that kind of makes it a peculiar indication for even treating asymptomatic WPW.
Dr. John is here.
Yeah. I agree with all the opinions expressed. And like Javed said, when we assess an accessory pathway and if we find that, it's a low risk pathway, we generally leave it alone. But like I also hear your point completely, Kapil, about you know it's a low risk pathway, but you're sitting on the pathway with an excellent signal, then you may just go ahead and give a buzz and get rid of it, considering the fact that the risks are very low. I mean, as long as it's not in a septal position and something else, then definitely yes, I can hear your point clearly on that as well. So I think generally, if somebody is 30 years plus and has been asymptomatic with a pathway, we generally don't go chasing after it. But in the pediatric population, we generally would assess the risks of the pathway. And in fact, our children who have accessory pathways and are picked up before 1 year of age or soon after 1 year of age, we generally do an esophageal EP study, document how risky it is, and then decide which way to go forwards.
So just Dr. John, do you ever see these accessory pathway which you pick up, say less than 1 year of age, disappear without doing anything as well?
Yes. In fact, 80% of accessory pathways that are there before 1 year of age disappear. But pathways which persist beyond 1 year of age seldom ever disappear. So that's, in fact, there are studies which show that, and we've seen that in our practice as well. So, which is why even children who actually present to us with in utero tachycardias and have accessory pathways, we do an esophageal EP study for them at the age of 1 to see if the pathway is still there and tachycardia is still inducible. And there are often that we find that the pathway has regressed, and then we just take the child off medications.
Good. So thank you, everybody, and we'll end this session. Thank you, Dr. Javed, for the presentation. We'll now invite Dr. Hariharan to present about the unusual accessory pathway. This should be pretty interesting. Thank you.
Good morning, everyone. Thank you, organizers, for giving me this opportunity. I'm going to speak about the unusual accessory pathways, with majorly ventricular pathway and atriovesicular pathway I'm going to talk about. Basically, you already, previous speaker talked about the accessory AV pathway. Accessory AV pathway is a short AV connection, but ventricular pathway, the name itself is there. So the insertion point is usually beyond the AV node, and it will insert into the ventricle. Then beyond the AV node and insert into the ventricle. This is the important point. And can you see this ECG, sir? Hello?
Yes, we can see the ECG.
Yes. With this ECG, the main differential diagnosis, lead 2,3 AVF is delta wave is positive, and there is a transition at the V1 bit A2 region. In this kind of cases, the main differential diagnosis will be the anteroseptal pathway and vesicular pathway. Here, the differential diagnosis is more important. And ECG wise, I'm going to talk about the points for the differential diagnosis. In the ECG wise, when compared to the usual accessory pathway, the vesicular-ventricular pathway will have a slightly larger PR interval when compared to the usual AV accessory pathways. And the second thing is, you should observe the delta wave amplitude. Usually for the vesicular-ventricular pathway, the delta wave amplitude will be very less. Usually it will be lesser than 2. And in case of the WPW, it will be around, it is more than 5, or it is slightly in the higher range. Mainly the vesicular-ventricular pathway will have the short delta. Okay, that is it. When we have the 2 to 5 millivolt thing, then we have to do the adenosine challenge test. That I will describe in detail. In the same patient, we can see this is the 1 minute, I will annotate. This is the A signal and this is the H signal. In the HV interval for this case is around 20 to 30 millisecond only. It is usually is short, and you can see the HV interval local EGM is also very less. Here, then we can go to the manuals for this thing. usually we will do for the vesiculoventricular pathway, the important maneuver is the incremental atrial pacing. In this is the incremental atrial pacing. You can see this is a drive cycle length of 500. This is the extra stimulus at 270 milliseconds. You can see the 12-lead ECG. This is the 12-lead ECG of the same patient. This is at 500 extra stimulus, and at a 270, we will not able to appreciate any difference of the increase in the pre-excitation, because vesiculoventricular pathway will have the fixed pre-excitation. Okay, and you can side by side, I compared the normal atrioventricular pathways here with 500 extra stimulus. You can see this much pre-excitation only, and with 430 milliseconds, you can able to see the increased pre-excitation. When compared to this AH interval, AH interval is increasing, and you can see the HV interval is constant at 500 milliseconds also, and with the 270 extra stimulus also. So HV remains the same, is the significant for the vesiculoventricular pathway. Here, in the case of the normal AV pathway, you can see the H clearly there and V is there. It is short only. With the extra stimulus, you can clearly see the H is actually buried in the QRS complex. And you should pay importance to the junctional beat also when you're doing the EP study, because and the same response will arise in the adenosine test also, because the origin is from the impulse arises from the this region, especially from the junctional region. It definitely will go to the vesiculoventricular pathway, so it will have the pre-excitation. In case of contrary to that, in case of the atrioventricular pathway, the junctional beats will not have the pre-excitation. Here you can see these are the first bit. This is the conducted atrial conducted. Here H is seen. Here you can see there is a no atrial thing, atrial region before that. So it is a junctional bit. This junctional bit will also have the same morphology as the previous bit. So this is definitely indicative of the vesiculoventricular re-excitation. Secondly, I'm going to talk about the atriovesicular pathway. Here, the atriovesicular pathway, this is embryologically, it is similar to the properties of the AV node. So this have the decremental conduction, we usually call it a Mahim pathway also, atriovesicular pathway also. The atriovesicular pathway, the term is correct. It usually have the decremental property as similar to that of the AV node. For example, in sinus rhythm, the impulse, minimally only the ventricle is pre-excited via the atriovesicular path. It majorly will go to the via the AV nodal route. So we will see the subtle signs only of the pre-excitation in the ECGs. With the maximal pre-excitation, the impulse go via the AV node also, and majorly via the vesicular pathway. That we will see with the atrial extrastimulus pacing. And during the reciprocating tachycardia, the Mahim pathway important role is it will conduct only in the antidromic conduction only. Okay, so it will this one anterograde via conduction via the atriovesicular pathway and retrograde conduction via the node. So it is always be a wide complex tachycardia with LPG morphology. So with this ECG, we can see the subtle signs of pre-excitation. Usually, in ECG, we'll have the Q wave in lead 1 and the AVL. Here, lead 1, especially the lead 1 is very sensitive when compared to the V6 also. Because in normal individuals in the sinus rhythm ECG, you can see the Q wave in 1 and the AVL. Here, the Q wave in lead 1 is absent, because initially the Q wave, what is the reason? Because of the septal depolarization proceeding from the left to right, you will see the initial Q wave in lead 1. What is happening in the atriovesicular pathway is the ventricular insertion site will be in this in the region of this anterolateral region. So it will not produce that Q wave in lead 1. And another feature also is to carefully look is a small R and a deep S in lead 3. Example, in S1, S2, S3 also, that syndrome also, you will have the S wave in lead 3 because of the counterclockwise rotation of the heart. In the normal individuals also, some case of pulmonary hypertension is any pulmonary this abnormality is there, you can see the small or deep S in lead 3. But in those patients, Q wave in lead 1 will be present. Here, you should take into that consideration presence of R DPS in lead 3 along with absence of Q wave in lead 1. That you should take into consideration. Both the things should be there. And V6 is also the lateral, but it is not significant because sometimes Q wave may present in the V6 because the insertion point of the atriovesicular pathway is distal. I already mentioned it is in the distal in the right bundle. So the activation may proceed from the apex to the base direction. So that's what Q wave may present in the V6 also. These are the subtle findings in the ECG to look for the pre-excitation in suspected atriovesicular path. Sometimes around 5 to 10% of the patient proven atriovesicular pathway patient will have the LBB morphology ECG at the baseline also. This is during the tachycardia. When you are seeing this one, it is a LBB morphology with late transition at the V5, V6 region and with the left axis deviation. Always keep the differential diagnosis of the atriovesicular tachycardia also keep in mind because the late transition because it inserts into the apical region. So the late transition is possible. In this, main differential diagnosis will be the SVT with aberrancy, atriovesicular tachycardia, and ventricular tachycardia. We can come to the diagnosis after doing the EP study. This is the sinus rhythm ECG. You can see the this is the atrial signal, this is the his signal, this is the ventricular signal. This is the I already told about the atrial extrastimulus protocol, basic cycle length of 600 basic pacing length with extra stimulus at 400. And this is the atrial extrastimulus 600. We are giving the extrastimulus at 310 milliseconds. Here we can see clearly the activation pattern from 3-4 from the proximal of the his catheter to the 1-2 region. Here also it is with increased. You can see in this thing the impulse is coming through the AV node also, but you can see differential between this complex and this complex with increased degree of pre-excitation. So the impulse is traveling via the atriovesicular pathway also and via the conduction system also. After the maximal pre-excitation, you can see clearly the signals is in the reverse direction. You are seeing his signal from the distal to the proximal. So the points are in the case of the atriovesicular pathway, the AH and AV interval will keep on increasing because of the decremental property. And at one time, predominantly the anterograde conduction via the atriovesicular pathway and retrograde conduction via the node. In this, the anterograde conduction is via the atriovesicular pathway and retrograde conduction is via the node. And in case of, and after this, the tachycardia will move like that. This is the tachycardia, antidromic tachycardia. The anterograde conduction is via the pathway, atriovesicular pathway. It is inserting into the right bundle. And this thing, it is retrograde limb via the node. This is the tachycardia, antidromic tachycardia. Here you can see with further differential diagnosis, we already narrowed out it. In case of the SVT with aberrancy for the patient, here with HV interval is for the tachycardia SVT with aberrancy, HV interval should be positive. Here HV interval is negative, so we can rule out the thing of SVT with aberrancy also. These are the points in favor of the atriovesicular pathway. Thank you, sir.
So again, very, very lucid presentation of the unusual kind of pathways. Now, sometimes we see unusual pathways also in terms of, wherever there is a extra point of contact of the atrial and the ventricular tissue. And that usually happens around the area of the tip of the appendages. So, when do you start suspecting that might be the case? And then what is your approach in such cases?
Atrial appendage tachycardia, sir.
Dr. Vivek is referring to pathways that involve from the appendage going to the V, Hari.
Okay, sir. This I didn't come across that appendage tachycardia.
So I
sir.
think, sorry, Chaser, you were going to say something.
Yeah. So it's very useful to see what the atrial activation pattern during tachycardia is and during the sinus rhythm. Normally, the way the catheters are positioned in the atrium, we can see proximal to distal activation in sinus rhythm. And if there is a distal to proximal activation, you know you connected your electrodes right, it will give us a clue. Yes, we have to think of it when in the annulus we are not able to get the pathway easily, but it's a very unusual tachycardia.
Completely agree. But the question arises that when it's in that typical area and you're not getting it from the endocardial side, so then that's when you start suspecting, and then obviously these are all high superior tachycardias because the activation is quite superior.
Yeah,
So
usually Vivek, we see a larger area on the annulus which has almost same timing with regards to atrial
yes.
activation. So that sort of gives us the clue that the source is somewhere beyond.
So then I think Dr. Yash, I think he's there in the audience, but whether he can comment or not, because even some of the paraseptal pathways, they are not really inserting into the annulus. Sometimes they are actually inserting a little bit more into the RVOT aspect of the ventricle. So these are all very, very interesting things, and we are all likely to come across them at some point. Although it's still very uncommon. Anyone else wants to share something? Kapil?
Just that vesicular-ventricular connections, you see them very often in cardiomyopathy, especially hypertrophic cardiomyopathy. And then, there is always a discussion whether pathway-induced dysynchrony is causing any problem and other things. So you have to be very careful when you see these pre-excited QRSs in cardiomyopathy patients, and make sure that you're dealing with vesicular-ventricular path, because they rarely cause any problem. So there would be many case reports which everybody can quote that they had a vesicular-ventricular pathway participating in a tachycardia.
Yes, and that reminds me another maneuver to look for to prove it's a vesicular-ventricular, besides different degrees of pre-exciting, is also that the pre-excitation remains the same irrespective of the location from where you are trying to pre-excite. So you could trace from RA, you could trace from proximal or mid CS. So I think with that, I would conclude this session, and I would ask Dr. David to make some concluding remarks and some other helpful pointers which might be useful for basic DM DNB trainees.
Thank you, Dr. Vivek. It's a good day of looking at pre-excitation, looking at symptomatic patients with pre-excitation. What do we do in those situations? What is the anatomy involved? And how do we approach routine case? Clinically first, rule out congenital heart disease, commonly Epstein's anomaly. In case of hypertrophic cardiomyopathy, it could be an acquired pathway. There would be ECG showing pre-excitation. We have had a situation where a patient with wide QRS tachycardia due to AF, pre-excited AF, went ahead and had an ICD implantation elsewhere, and I follow up that patient now. So need to be aware what pre-excited AF looks like. Very varying RR interval, first suspect AF. If the QRS is very wide, it looks like there is a delta wave. It's quite likely pre-excited AF. Keep that in mind. Try and get a ECG of sinus rhythm if available, and look for pre-excitation in that stage. I'll see a report note from Dr. Yash Kapundwala and relevant discussion. Further, I've also had situations where we see patients who need ablation, and they're not easy to ablate. All of us have had that kind of an experience, and we may have to redo procedures where 3D mapping may be helpful. We had situations where pathway procedure itself can lead to complications, especially if we have AV node block happening during a posterior pathway, right-sided posterior pathway ablation, or if somebody had no AV node connection to start with at all. So it's important to have an idea about what's going on with the patient in the baseline state before we take the patient up for ablation. Fabry's disease, storage disorders can also be causes for acquired pre-excitation where we may or may not have to do much. We had a discussion about symptomatic patients. What do we do? Understanding that pre-excitation means it can pre-excite anywhere, either at the node, below the node, the vesicles, or directly into the ventricle. And understanding that will help us look at antegrade pre-excitation. Retrograde pathway conduction in the setting where there is no pre-excitation in the baseline ECG or no evidence of pre-excitation at EP study, which essentially is the concealed accessory pathway. In that situation, we look for atrial pre-excitation and we use EP assessment methods to evaluate and decide where to ablate. Ablation is a good procedure. It easily is able to get rid of pathway conduction in most circumstances. When not to ablate, or when we don't even subject the patient to EP study, is also part of the discussion. If it is right on the His bundle, we'll be cautious. We look for other areas where we need to ablate from. We could go back into the RV. We could go back retrograde aortic and see if we can get somewhere in the sinuses rather than getting close to the AV node in the AV junction is an approach used in that particular situation. There will be other methods. From the days of the original RFA procedures, we started with a surgery to actually identify that pathway and then ablate it. It was a very complex thing. We have come a great distance and it's so easy to do EP studies in RFA. So in a center with all the necessary resources, we should be able to do it very easily. Should not have a high threshold for doing a procedure, especially in symptomatic patients. In asymptomatic patients, we have to have a cautious approach. We've discussed special circumstances under which we may have to consider doing an ablation procedure. We have discussed circumstances where the risk is low. Anand has made a note about ablation during A pace or V pace. In a concealed accessory pathway, when we are ablating during tachycardia, if the pathway gets either bumped or during ablation terminates conduction, it may not be possible to complete the lesion at that point. If you don't do V-pacing at the same time, around the tachycardia rate is the point which most people follow in their procedures. Yeah. Similarly, in A-pacing is required to look for AV node conduction if you are somewhere close to the AV node. If we see that during A-pacing, we are finding some prolongation of AV conduction, that means we are actually causing harm and we would like to avoid AV node damage at the time of pathway ablation. With this, I would conclude and I would like to leave it to the chairperson to decide when no questions need to be answered.
Thank you so much, Dr. Chase, for a very succinct conclusion. One thing I think I felt was left behind in this discussion on accessory pathways. So, John, if you could quickly, give, tips to the fellows on pharmacological do's and don'ts of management of WPW, because that is a very, very, mistreated lot.
So, yeah, I would not give amiodarone to somebody with a WPW, particularly because these are young patients and you don't want to give them a drug which has multiple side effects in the long term and put them on these drugs for long term. But having said that, there may be a role for amiodarone in the pediatric population where you've tried all other drug combinations and it's failed, then you may have to give amiodarone. Same way, when we are talking about treating patients with drugs, there's always this concern about giving beta blockers or calcium channel blockers which block the AV node, but don't necessarily have much effect on the pathway. There is a bit of a controversy there in that beta blockers can act on the pathways as well. And there are some people who advocate just giving beta blockers because it has some amount of action on the pathway as well. But there's not much evidence about calcium channel blockers having action on the pathway. So generally, it would be safer to give an antiarrhythmic like flecainide along with a beta blocker when you're giving it to somebody with an accessory pathway. And the other question that often people ask is about giving adenosine. And in fact, one of the people asked about giving adenosine to a patient who's had documented antidromic tachycardia. How safe is it? Yes, adenosine can reduce atrial refractory periods and can precipitate atrial fibrillation. So that is something you have to be wary of, because you may end up terminating the antidromic tachycardia, but precipitate AFib, which can degenerate to VFib. So adenosine should always be given at a center where you have a defib machine available to use as and when necessary. So I think that's it.
Kapil, you want to add something?
No, I think everything has been discussed, though this is a big topic. We can't cover everything, obviously. But I think for the fellows and for the cardiologists, general cardiologists, it should have been a good discussion. Nothing much to add. Thank you.
So thank you so much to everyone, our speakers, Dr. David, and my fellow moderator, Kapil, for this excellent session. I would like to thank the hosts for hosting this. And with that, I would like to conclude. So have a nice Sunday, everyone.
Thank you.
Bye-bye.
Thank you, Vivek. Thank you,
Thank
Kapil.
you all.
Thank you all.